and welcome. We're very happy to see that such a good turnout to discuss an important topic today. I think you are all aware that today is the International Metastatic Breast Cancer Day, and so we are very happy that you are here with us for us to go through some short presentations and especially to discuss topics that are very crucial and important for metastatic breast cancer patients. Just 2 or 3 notes. Because so many people register, we will not be able to give you the floor to ask your questions, but please use the chat function in the WebEx, and we will try to answer your questions as much as possible. A note also to tell everyone that this meeting is being recorded, so don't say anything that you may regret later. And then to the speakers, please unmute yourself when it is your time to speak. I hope the system allows you and not does the same to me as it did to me. So today we are going to start. I will do a brief introduction to metastatic breast cancer, and then we will have Eva Schumacher to give a personal testimonial about living with this disease. We will then go for 2 specific presentations, one about the Aurora research program led by BIG, and Dr. Philip Aftimus will do that presentation. And then we'll speak about a very specific situation in metastatic disease, which is oligometastatic disease. And Dr. Frederick Van Doven will give us a presentation about what is that and what can we do different for this specific type of disease. So without any further ado, I will share my screen and start my presentation. Okay, I hope you can see me, but if not, just let me know.
Yes, we can.
Thank you. So let's go and discuss a little bit what is metastatic breast cancer. Move the slide. So in a very simplified way, you have here the different stages of breast cancer. On your left, you can see that we have early stage breast cancer when the disease is located in the breast and the axilla, the armpit. So that is considered like an extension of the breast. And so even if there are lymph nodes in the axilla, we still consider early breast cancer. And this can go from stage 1 to 3. Usually stage 3 we call locally advanced already, some parts of stage 3. And then there is one situation where the disease has left this area of the breast and axilla and has spread to other organs of the body, and we call that stage 4, advanced or metastatic breast cancer. In the major difference is that early stage breast cancer is potentially curable, while metastatic breast cancer is for the moment uncurable. But advances have been made, and perhaps in the future we may be able to change this, at least for some of the subtypes. In terms of diagnosis, in the so-called developed countries, 10 to 15% of patients are diagnosed already at stage 4. But unfortunately, in developing countries, this can go up to 50, 60, and in some countries, even 80% being already diagnosed with metastases. And this is just a clarification about the different terminology that we sometimes use, so to make it very clear for everybody. Why we sometimes say advanced breast cancer, sometimes we say metastatic breast cancer. So advanced breast cancer comprises 2 situations. One is what we call inoperable, locally advanced breast cancer, what you see in the figures on your left, in an MRI, and also a very sad photograph that it's there. but it says it's a disease that although it's localized to the chest, it is so extensive that no local therapy can take care of it. And the other situation is metastatic that you see on your right, on an image of a PET CT, where you see metastases to other organs. And the most frequent is bone, liver, lung, lymph nodes, and brain. And this is called stage 4. And there are some countries, particularly the UK, where you call it secondary, which is a terminology I don't really like because it's not secondary always. And it seems like it's second class. And so I don't particularly like secondary, but it's also another name. So why does metastatic breast cancer occur? It occurs because cancer cells, which are actually our own cells that become crazy, let's say, they gain the capacity to grow, to proliferate and grow without control. And they also gain the capacity to invade the blood vessels or the lymphatic vessels, but particularly the blood vessels, and go to other parts of the body and there grow again and give the metastasis. So this is the mechanism why we have metastatic breast cancer. And why do we need a special day and special consideration and focus for this disease? So in this curve, you see the mortality rates for early breast cancer. And you can see this is the example of UK and the USA, but actually it's the same for almost all European countries. You see a very deep drop in the mortality since the 90s. So why this happened? Almost 30% reduction in the mortality, because we have the capacity of doing screening and early diagnosis. Education and advocacy awareness also became very important. And we have very good, what we call adjuvant treatment, what we give besides surgery and radiation, chemotherapy and tamoxifen. All these things started to be done in the late 70s and 80s. And so from the 90s, we start seeing this huge impact in mortality. However, when you look at the evolution of metastatic breast cancer, this is unfortunately not the same. We almost don't see a difference in the overall survival, which remains about 3 years, with very, very small increments on each decade. So there's clearly, we need to move faster and improve the outcomes faster. This is a bit different if you're talking about something that it's already diagnosed as metastatic. The median survival is a bit bigger, about 5 years, or that is a recurrent metastatic. And why is this? Because this recurrent means that the patient had a diagnosis of early breast cancer, was treated, usually with the best treatments that we have, and then has a recurrence. And there the overall survival is lower. We also know there are specific problems linked to metastatic disease, particularly feelings of loneliness, of being abandoned, even by the advocacy groups, and also feeling guilty if the fault is from the patient that the disease has come back. And a lot has been done in this last decade, but still you can see here initial surveys done in the early 2000s and repeated 10 years later. The numbers have improved, but they are still worrisome. So how can we change this? To try to change this, we have created the Advanced Breast Cancer Global Alliance, and we have members from almost 90 countries all over the world. And the word that defines the work of the Alliance is sharing resources, sharing knowledge, collaborate, and use the resources that we already have to improve these outcomes. And I invite you to read this ABC Global Charter that's available online, where all of us together, the patients, the advocates, the healthcare professionals, the policymakers, we came together and defined 10 goals, 10 achievable goals that we should be able to achieve in this decade that we are living, including improving survival and improving quality of life. So when we started looking at this, we said, okay, what happened in the early breast cancer? that made such big advances, and can we apply it in advanced breast cancer? And two main things happened. We started to treat early breast cancer in a multidisciplinary way, and we had very strong guidelines. So this is what we've been doing also in advocating for the metastatic setting. Strong guidelines, implementation and treatment according to guidelines, and also availability of multidisciplinary care. And you will see in the last presentation how important multidisciplinary care is for oligometastatic disease. So I also want to invite you all, in a couple of weeks, we have the Advanced Breast Cancer Consensus Conference, where we will update the guidelines. So please join us and let's update the guidelines together. Three examples before I finalize of the work of the Alliance, of the work that we all have to do. First, do we even know how many breast cancer patients with metastatic disease exist in Europe or the world? The answer is no. We know incidence. We know that every year, 2.2 million new cases of breast cancer occur. We also know that every year, more than 6,000 patients die, most of them women, with breast cancer. And we know something called prevalence. That means that someone had a diagnosis in the last 5 years and is still alive. And this is almost 8 million people. But this includes all the survivors as well as the metastatic cancers. So what we need to do is change the way registries are being done. And this is something the Alliance is working with IARC to make sure that we have data on how many metastatic breast cancer patients exist. Also, and to finalize my talk, I wanted to call the attention that if we want to manage metastatic or advanced breast cancer properly and patient-centered, there is no room for stigma, and stigma still exists. This was a question asked to the general population of all those countries that you see below. And the question was, do you think that someone who has metastatic disease should keep it a secret and should only discuss the disease with their physician? And you can see that 1 out of 4 or 1 out of 5 people think that still all over the world. So I will end my talk with a short video of 90 seconds where you can listen from the voices of the patients exactly what it means to have this stigma and lack of awareness. So let's hear the movie.
It sometimes feels like a price is being put on our life, and that isn't right.
They just look at you as a walking corpse.
You know, I am living probably their worst nightmare.
It is treated like a curse.
They can't understand that there's no happy ending, no getting better.
No, let's not use the money for treatment because she's gonna die anyway.
Thinking about my kids is difficult.
I am
Advanced
Breast cancer.
So I hope that this video on the voices, with the voices of the patients, allow you to understand exactly how they feel, but nothing better than listening from a patient herself. And so I now invite Eva Schumacher. You saw her in the movie, and now she will say a few more words about the experience of living with metastatic disease. Eva, the floor is yours, please.
Thank you, Fatima, for your introduction and really from the bottom of my heart for everything you're doing for the metastatic community and for each one of us individually. I don't know how you carry all of us on your shoulders. Sometimes I think you must break down, but you carry us and you carry the community and you really make a difference for us. So thank you from the bottom of my heart for this, really personally. So yes, I'm the one in the movie that it's difficult for me to talk about my kids. This was before chemotherapy. That's maybe you thought, who was she? Because I looked a bit different. But anyway, so we talk about metastatic disease, thinking about that it's Breast Cancer Awareness Month, and only one day during this month is dedicated to metastatic disease. I think that has to change, first of all. Now, when I've been asked what is my future as a metastatic breast cancer patient, so I would rather ask, do I have a future? And how does my future look like? Being diagnosed with metastatic breast cancer suddenly puts me into a roller coaster. So I'm one of these late recurrences that we don't know so much about it. Like I had a recurrence after 14 years, so I was diagnosed with MBC in 2018. And since then, yes, I'm sitting in a roller coaster, but it's a ride that is, first of all, no fun. It's a ride that I haven't booked a ticket for and I didn't want to sit in, but I can't get off. And I have to do this ride until the end. And there's, as you heard in the movie, there's no happy ending. So, but there's a ride on the way. It starts probably with diagnosis, so we are on the floor. Then when we are lucky, we have a treatment option, and then the rate goes up, so we can have, in the best case, when we have a good adverse or side effect management, so we can have a good quality of life and we come back to our normal life. But then we come to a point that it's a new staging, so then it starts all again. Either we have another treatment option, or its treatment is still working, so we go further up and we are happy, we are relieved, or we hear that treatment is not working anymore, we have to find a new option. So you go all the way down, you smash on the ground and you have to start all over again. And when I say you have to start all over again, it's like sitting there and going, okay, now I'm closer to death because one treatment line is over. I have maybe a few treatment lines only left, so I have to organize my whole life once more. I have to think, what are my preferences? Am I doing the right thing with the remaining time? And how much time is remaining? So how can I, do everything I want to do in this short time that I don't know how short it is, but each progression is the time to really organize and rethink the whole life. In my case, it always takes me 3 to 4 days that I'm like, I can't move. I'm just sitting there thinking, okay, how can I continue? And then again, in the best case, there's a new treatment option. So I start walking again and I start living again. And this is the roller coaster that I mean. It's really up and down. And I have to say that the ups are beautiful because there are so little moments that you're really up on the roller coaster and you go like, whoa, that's life and I can enjoy it. It's wonderful. And you know that it's just a question of time until you go all the way down. So being on top is something really amazing. So we have wonderful moments, even in the life with metastatic disease. But what do we need? I said, the question is, do I have a future? So I want to tell you a few points that I think we need, the community needs, if we want to have a future. So first of all, we need further research and treatment options. And you will hear in the next talk, I think, a research project that is really, really important for us, Aurora. I hope it will make a difference. We need the interdisciplinary care team that Fatima was talking about. I think this is really important. And we need a trustful and open relationship to this medical team. We have to discuss like what are the preferences, what I told before, and preferences might change with each progression. Preferences might change because my life is shorter and the options are less. So we have to discuss once more, what is your preference? What do you expect from life? What do you expect from treatment? And I need this really time to discuss and this very trustful relationship to my medical team. Otherwise, I will feel left alone, and maybe, you know, the care team will provide some treatment options that I'm not, you know, standing behind, and then it will be difficult to arrange with the treatment. So I think this communication is so important, and we should have much more time for this. I know that in a big clinic, every day's life, it's difficult to really sit and focus with the patients. And I'm not pointing finger on doctors. I know that it's amazing what they're doing. I just wish we had more time for this personal, really talk and an adjustment of what we expect and what our preferences are. And what we need is reliable and understandable information. I think this is really crucial, because if we want to discuss with a doctor and be a partner and have a shared treatment decision, we need information, and this has to be really like also latest information of congresses, new data, new treatment options, but also options about supportive care, which is so important. I think in many cases the whole management of adverse events could be improved, it's not a one-way road, because patients have to communicate very good what their problems are. Otherwise, the care team can't react. But I think this whole management of adverse events is one of the crucial parts of the cancer treatment. And I wish for all this was more time and this understandable, reliable information in layperson language. This is, I think, what we can't have enough from. So the goal, I would say, for the whole MBC community is, I wish all of us would be treated according to the ABC guidelines. I know, talking on a global view, this is a big goal. But why to think small if we can think big? I mean, I'm a patient advocate. I want the most for every single MBC patient in the world. So that's what we make the ABC guidelines for. And this is, again, something that Fatima had kind of, it's her baby, the guidelines, and they're amazing. And you all know that in the beginning of November, these guidelines will be discussed again, and probably there will be some changes. So I hope all of you will follow these guideline, or the first of all the talks, the ABC Congress, and then also the new guidelines, because then you know what you owe your patients, because this is what we want to have. And I know, again, it's difficult and it's different from in all parts of the world, but I want the best. So that's the goal, and I think it should be the goal of all of us. We want treatment according to ABC guidelines for all patients, no matter where they live. So with this, I stop here. We have a talk about, I think, really important research project, an important topic about oligometastatic disease that when I look in my community, so there's not so much special treatment in this oligometastatic disease. It's usually being treated like, you know, other metastatic diseases. So I think it's a very important point, and I'm looking forward to the talks and maybe some discussion in the end. Thank you very much.
Thank you so much, Eva. Always wonderful to listen to you and to understand what is truly important for you. And thank you. I also wish that everybody would be treated according to the guidelines. I'll keep on fighting until I have no more voice.
So do we.
Okay, so we move now to the presentation about the Aurora research program. As Eva said, we have high hopes that these can be really changed of practice in the future. So Dr. Philippe Aftimos from the Jules Bordet Institute and also BIG will be presenting. Philippe, the floor is yours.
Thank you, Fatima, for the presentation, and I thank the organizers for this opportunity. And thank you, Eva, for your testimony, which is very poignant and yet very motivating for us. So I would like to present to you today a very important program in metastatic breast cancer called the Aurora Molecular Screening Program. This program has been promoted by the Breast International Group. The Breast International Group is what we call a group of groups. So the objective is to put all the collaborative groups together in order not to have redundant research. And I think this is why this group has been spearheading this project. This project was performed in Europe, but it has a sister project in the US called Aurora US. And that was made possible. Aurora was made possible by a very generous grant from the Breast Cancer Research Foundation. So why Aurora? So here are the study objectives. We have learned that actually early breast cancer can be different from metastatic breast cancer. And now we base our therapies, and we know that from the guidelines, on the metastatic sample, the secondary cancer. So Aurora has the objectives of understanding what causes the relapse of patients treated for early breast cancer. We can have two patients with the same cancer treated with the same therapies, but one patient will develop a relapse, the other not. So we need to understand what drives relapse in order to improve the cure rates. The discoveries can allow new treatment strategies. So we can, again, improve the cure rates, but also improve the outcome of patients with metastatic breast cancer. And then we have the concept of precision medicine, or what was called previously personalized medicine. And data from Aurora, since it is given back to the oncologist, can also facilitate precision medicine therapies. Now, what data have we used in Aurora? So in order to understand why breast cancer becomes metastatic, why some patients develop relapses, we wanted to compare the primary tumor, so the tumor that was in the breast at the diagnosis, to the relapse specimen or a metastatic specimen. And in order to do that, we use the new technologies that allow us to study DNA. We also collected clinical data and follow-up data, so the demographics of the patients, all the therapies they received, the outcome in therapies, and this allows us to correlate the biological findings with the clinical findings. And this is important to understand why some therapies work and others not. So the biological data we have come mainly from what we call gene sequencing. So gene sequencing is the process of determining the information or genetic code contained in the DNA from the tumor. And when I say gene sequencing and DNA, we will definitely think of hereditary genes, but actually we know that you can have genes that change only in the tumor. And those are the changes that we study in Aurora. We also study changes in liquid biopsies. So liquid biopsies is, well, I guess you are all familiar with the concept of a biopsy, which is quite an invasive procedure for the patient. With a blood test, we can perform what we call a liquid biopsy because we can find DNA shed from the tumor cells in the bloodstream, and we can study that. So Aurora, as I said, is a European program, and it recruited patients in a very nice collaboration between the groups in 60 centers in 11 European countries. And you can see the spread here in this slide. Now, what did we do in Aurora? I would like to schematize a bit the flow in this slide. So we recruited patients with relapsed metastatic breast cancer that did not receive a lot of therapies. So patients were early in the course of their disease. They had not been treated for metastatic breast cancer, or they only had one line of therapy. Because we know that therapies can alter the mutations, the DNA of the tumor. And in order to really compare the primary tumor to the first metastasis, we wanted to collect them very early. So we collected the samples from the breast tumor, from the metastasis. We also collected blood. the so-called liquid biopsy. And we had an IT platform that would allow the physicians to follow the different steps. So sending the samples, getting the results. So the samples were evaluated in a central lab, and we have these slides that are digitalized and that can allow also future research and artificial intelligence projects. And we did the gene sequencing analysis on all the tissues. So the primary tumor, the metastasis, but also the liquid biopsy. So we could look at up to 400 genes that can be associated with cancer. We had the results so far of 1,158 patients. And all these results were analyzed by a group of experts called the Molecular Advisory Board, because we would send back the report to the clinicians, to the physicians, with advice on how they can treat their patients. Because as you know, some of the findings can allow us to treat patients with targeted therapy. So as I said, precision medicine or personalized therapy. Now, to summarize a bit the first results that we published recently, so these are really the first results. So Aurora can allow us to identify these gene abnormalities that are really enriched, that we can find in metastatic breast cancer when compared to the primary breast cancer. So this means that these genetic abnormalities can be driving the disease, the metastatic relapse, and are interesting for us to develop therapies in the future. So in 10 to 30% of cases, we could find at least one additional genetic abnormality that was not in the primary tumor, and we are able to identify which ones. Now, Aurora also, by comparing the two samples, allow us to study what we call subtype switching. So I guess we know that breast cancer is not one disease. We have three main subtypes. The subtype is the hormone receptors, the subtype that is called HER2 positive, and the subtype called triple negative. And all these subtypes have different treatments. We know that from the primary tumor to the metastasis, in a subset of patients, the subtype can change. But by studying also the expression of the genes, we can identify what we call subtype switching. And this can also impact therapy. So we could identify a change in the subtype, in the intrinsic subtype, in about a third of the patients. And this is a lot. And I think this is important information. Aurora also allows us to study the immune cells. So cancer usually develops because our immune system cannot destroy the first cancer cell. And the cancer then will put our immune system to sleep. And this is how it develops. So when we use immunotherapy, and immunotherapy is used in a subtype of breast cancer, it's to activate our immune cells. So when we compared the primary tumor to the metastasis, we saw that actually there was a depression of the immunity in the metastasis. And this is what we call the immune permissive cells. And then, as I said, we had the clinical follow-up, so we can see the patients that had relapses quite quickly or later relapses, and to try to identify biological processes associated with the worst outcome. And we could identify one, and you can see here clearly in the blue line, these are the patients that had a relapse very early versus patients that had a relapse quite later. And actually, when we find these kind of biomarkers, we can incorporate them in future clinical trials. Now, an important aspect was giving back the results to the oncologist in order to practice what we call precision medicine, meaning using unique therapies that treat an individual's cancer based on the genomic abnormality. So for each genomic abnormality, we could have a therapy. An important finding was that for more than half of the patients, we could find one molecular abnormality that has a drug either in the clinic or in a clinical trial. So I'm an advocate of really trying to offer genomic profiling for all patients. However, you can see that we only have a dismal number of patients treated with a drug targeting the abnormality, only 7%. And this is for many reasons, either because the drugs are not available or the clinical trials are not available, and because we have heterogeneous patient population, so we must do better. And finally, from the liquid biopsies point of view, we know that we can also select the therapy based on the results from the liquid biopsies. So we showed that liquid biopsies are complementary to tissue biopsies. Now, what is the future of Aurora? Aurora is a very important program because it will empower future research. There is a huge biobank of tissue and plasma samples that can be used by researchers all over the world in order to make discoveries. But there's also a huge database of clinical and follow-up data that can be used also that we can correlate to the biological findings. And I think this is a gold mine that in the future might allow us to better treat metastatic breast cancer. And actually, the program will enroll patients in the future in specific subtypes of unmet need. And as I said, this program is a collaboration, European, but also a world collaboration. And you have many people that are involved and that we would like to thank. But most of all, we would like to thank the patients because the patients donate their samples and time. And we would like also to thank their families. And thank you for your attention.
Thank you very much, Philippe. I just want to, before we go to our last speaker, just to remind everyone to please send your questions through the chat. And we have a lot of time at the end to answer any questions that you may have. So please go ahead and use the chat. Thank you, Philippe. And we go to our next presenter. So we will be speaking then about oligometastatic disease so that you can understand exactly what is this specific situation and what can we do differently. So it's my great pleasure to introduce Dr. Frederick van der Hoven from the Netherlands Cancer Institute in Amsterdam. So Frederick, please, the floor is yours.
Thank you, Fatima, and thank you, of course, everyone participating today and helping us in our quest to, of course, try and treat metastatic breast cancer, because that's our ultimate goal, of course. Let me start by sharing my slides, which should work now. So hopefully you can all see this. So I'm going to try and inform you about oligometastatic breast cancer, which, as Fatima has indicated, is a specific subset of metastatic breast cancer. So I'm a surgeon, not a medical oncologist, and I work in. Oh, it's not working?
We
no.
can't see your
Oh, wait.
slides at the moment.
Yeah. Oh, yeah. Stupid.
Surgeons.
Window. Yeah, it's too difficult for me. So there we are.
Now
it's better, right?
That's much better.
Thanks. Sorry about that. I was going too fast. So there we are. So about oligometastatic breast cancer. Well, for starters, of course, the question would be, what is oligometastatic breast cancer? Well, first we start
Frederica,
with what
if you can put it into slideshow mode, that would be great.
It is in slideshow mode.
We can only see the back end at the moment. Would you like me to present the slides?
From beginning, so here. For me, it's a slideshow, not for you.
No, we're only seeing the back end of it.
Okay, well, if you can present, it's fine, of course, as well.
Hold on
so I will stop sharing. Oh, and I made some changes, though. Well, we'll be fine. I know we have some time. Shall I try one more time?
Yeah, do you want to try one more time? Yeah.
Yeah, so share screen, window, share. This you see?
We still see the back end at the moment. So if you start the slideshow.
Start slideshow. Start from beginning.
No, we're still seeing the back end.
Okay, well, then I'll stop. Then I'll rely on you.
Okay, no problem.
Well, thank you. Thank you for starting the slides. So first, we're going to have to talk about what the definition of oligometastatic cancer. Quite recently, there was a consensus by several international organizations to define oligometastatic cancer, so not specifically breast cancer, as disease that has spread to 1 to 5 metastatic locations, with all metastatic sites being amenable to safe local regional treatment. And also, in addition, the primary tumor, if present, would also have to be amenable to treatment. So that is for all metastatic cancers. So the next slide indicates a further subdivision of, in this consensus document, you divide the metastatic disease whether or not it occurred at the same time or close to the diagnosis of the primary tumor or at a later stage. Also, you can make a division into disease that was new or that was previously treated and recurs. So that led to quite a complicated schedule of, in the end, of 9 subgroups of oligometastatic disease. I'm not going to bore you with that. So the next slide is more important, of course, since, this was the very complicated slide that I later on deleted. So next slide, please. So what we want to discuss is what is oligometastatic breast cancer, because obviously we cannot just extrapolate data from all cancers to breast cancer. So on the next slide, the question, of course, is, can we use the same definition? Well, first of all, we have to take into account that breast cancer consists of various different subtypes. Philippe already mentioned some of them, but for example, you have the triple negative subtype, which is a breast cancer that is not that does not have hormone receptors nor HER2 receptors, that has a completely different biological course of disease than the hormone receptor positive breast cancer. And also, the location of the metastasis is important. If you have disease in the brain or in the pleural cavity, then the prognosis, unfortunately, is much worse than for patients with bone-only disease. So also that should be considered. And of course, in breast cancer, as in all cancers, the timing is important. Fatima had already showed us that if you have disease at the same time as the primary breast cancer, we call that synchronous metastatic disease, your prognosis, your overall survival will be better than when you develop metastasis at a later stage. Next slide, please. Then, of course, we need to differentiate the oligometastatic situation from the normal metastatic situation. Well, for metastasized breast cancer, there are no curative treatment options. I mean, there is long-term prolongation, of course, for survival, but the treatment of the metastases themselves will not further improve your survival. So if you have this situation with, say, 10 or 20 different metastases throughout the body, treating 1 or 2 of them does not, in the end, prolong your survival. It may help for specific local complaints, but is generally not indicated. Whereas in oligometastatic breast cancer, that has a more favorable prognosis, and it may be worthwhile to actually eradicate all the lesions up to 5. We feel that with this treatment, long-term palliation and even curation might be possible. Yes, next slide, please. So, of course, this is not something new. In the past years, several studies have examined this concept. I sort of miss here the, maybe next slide is better. Thank you. Yeah, because here I've highlighted some important points from these slides. It's a much information on the slide, so but what I wanted to share with you is what you see in the third column with the highlighted squares here. That is the column that indicates which patients were included in these clinical trials. In green, you see the mode of diagnostics that was used. So in some studies, it's not even specified how well did you look for metastasis. In other studies, an FDG PET-CT scan is used. I will tell a little bit more about that in the coming slides. And also, there was a difference between which patients were included. In some studies, you were allowed to have up to 5 metastases, but only in the lungs or in the liver. And in other trials, you could only be treated if you had 1, 2, or 3 metastases in the bones. So a completely different patient population within each trial. And in these trials, there was no comparison, no direct comparison with untreated patients. So all patients in these trials were treated for their oligometastatic disease. Given the heterogeneity of these populations, so the big differences in which patients and the mode of treatment, the mode of looking at those metastases, these clinical trials do not offer us sufficient evidence to say that treating oligometastatic disease is definitely beneficial for all patients. So we need a bit more than this. Next slide, please. Given these results, that of course makes us want to question how hard should we look for oligometastatic disease? If we're not sure that treatment is beneficial, should we try and find it? Well, currently, since metastasized disease cannot be cured completely, the international guidelines suggest not to go and look for metastasis if you think that the chances of there being metastasis present are low. So only in case of a clinical positive axillary lymph nodes or a very large tumor or a specific very aggressive breast cancer, and if the breast cancer recurs, it is indicated to try and identify metastasized disease. So only in that case would you do a scan of the rest of the body or ultrasound of the liver. And the goal would be to find metastasized disease, because if the patient does have metastasized disease, you would not start intensive local treatment, but rather focus on systemic treatment to prolong survival. Next slide. What about a situation when a patient was treated for early breast cancer, as Fatima indicated at the beginning, and is followed up? Many patients ask me, why don't you go and check to see if I have metastasized disease? Because I don't feel comfortable and I'm uncertain as to what is my current situation. So is it better to detect the metastasis by doing regular scans rather than waiting, which is what we do now, for a patient to show any symptoms? So what we do now is, if there are no symptoms, then we will not go and do scans of the rest of the body. If there are symptoms, we will specifically do additional examinations. Well, so far, research has indicated that intensive follow-up with regular scans does not improve survival. However, next slide, this may change, as Fatima has shown, and the Aurora project hopefully will also give us more information and options. There will continuously be better treatment options. And in the future, hopefully in the near future, it may in fact be much more realistic to expect long-term survival or even cure from treating metastatic disease. So next slide. Especially for oligometastatic disease, of course, because if there's a limited number of metastases, it may in fact be worthwhile to find them so you can treat them. So if we want to go ahead and look for metastatic disease, specifically for oligometastatic disease, it's very important to consider the modes of looking. So you can check the patient's body in numerous ways. Conventionally, so standard would be to do a CT scan of the chest to check for lung metastasis. A picture is shown, the upper picture is of the CT scan. You can do a CT or MRI scan of the liver. Below left is a liver with the arrow pointing at a metastasis. And you can do a bone scan on the right side of sort of the skeleton figure you see, which can find bone metastasis. So those things we can do in more or less standard way, but we have also new imaging methods. So a PET scan, which is below with the orange areas, so which is a combination of a nuclear medicine scan with a CT scan, which is much more sensitive into finding the metastatic disease. And we can use MRI scans for bone lesions as well. On the right side here, you see a vertebral column. So on the next slide, we can see the difference between these two methods. So on the left side here, you see a bone scan, so a standard bone scan, which has been available for decades. And we see here, I hope you can see it, but there's a black lesion in the middle of the vertebral column. It's a metastasis. But then if you use one of the newer methods, such as an MRI scan of the vertebral column, I hope you can recognize that all these sort of white dots, they don't belong there. So when with the sort of standard methods, you might find a patient to have, one metastasis, a very good candidate for oligometastatic treatment. If you look more closely using other techniques, you may actually identify more disease. And of course, it makes a big difference which kind of patients you would include in a clinical trial with which methods. So on the next slide, we continue also, of course, with the differences in treatment. You can do surgery. In my opinion, of course, always a good plan. But specifically for liver metastasis, you can do resection. But what is also very much used is to do stereotactic radiotherapy. You can use that for both the liver, the lung, and the bone lesions. So on the next slide, we see the differences. Here we see the stereotactic body radiotherapy. You see the patient here lying in a elaborate machine, a radiotherapy apparatus. And what happens is that from many angles, you direct a radiotherapy beam, which eventually focus on a specific point, the tumor or the metastasis. So it's non-invasive, whereas surgery, of course, is invasive. There are also less invasive methods in which you use thermotherapy. So you sort of insert a probe into the patients through the skin, and then you can sort of burn away a liver metastasis. So there are also differences in treatment. So on the one hand, the differences in how do you diagnose the treatment, and on the other hand, the differences in how do we actually treat. Yeah, next slide, please. This is also a very busy slide, but just wanted to show you that there are several trials ongoing with treatment of oligometastatic breast cancer. In almost all the trials, patients are either treated with standard of care, so with the chemotherapy, immunotherapy, plus or minus treatment of the oligometastatic lesions. There are some differences in the kinds of patients that are allowed to enter. The number of metastases usually is up to 5, and in most new trials, the newer imaging methods will be used. Next slide, please. Given the time, I will speed up a little bit. So these are also more slides. There will be a video of the presentation, so you can always go back and check the trials. Next slide, please, because I wanted to highlight one of the European trials. That's the Taormina trial, which we hope to be
Frederic, please unmute. We cannot hear you.
I think, Frederick, we've lost your sound.
Yeah,
There we go. You're back.
yeah. Somebody, I'm not pushing any buttons, but somehow I'm automatically unmuted, which is not a good sign, but understandable. So just a few more slides on the Taormina trial, which is a single-arm phase 2 trial that was initiated by my colleague in Sweden, and which we hope to be able to expand throughout Europe. Yeah, next slide, please. I will make it a bit faster. Originally, we thought to include patients and have the computer decide whether or not to treat the oligometastatic disease. So either you would get the standard of care with systemic treatment, or you would get the same treatment plus radiotherapy of all the lesions. Oh, yeah, there we are. So in this original design, patients and doctors were not allowed to choose. Well, we checked this design for starters, with physicians, but already they indicated that they would not feel comfortable to allow the computer to decide the kind of treatment. Patients, we expect, of course, patients would rather have the treatment of the oligometastatic disease, and most physicians also, we feel that it is necessary, if possible, to treat the oligometastatic disease. Next slide, please. So in the new study design, all patients will be treated. So maybe you're asking, why do it in this way? Because already there are some clinical trials running. But what we want to do is to have a European group of patients who have all the sort of the same characteristics, so we can get reliable information on the benefits of treatment of oligometastatic disease. Yes, next slide, please. So also in this study, you can have up to 5 metastases, and you should have a stable disease when you're first treated with systemic treatment for breast cancer. Yes, I think that was my last slide. Oh no, of course I have to take home message and the expectations, I'm sorry. What we think is that with treatment of oligometastatic disease in this trial, we can improve the overall survival with 10%. So if we take a look at patients included after 3 years, we think that 10 out of 100 extra patients will be alive if we treat the oligometastasis. Next slide, please. So we're still waiting for some research, some feedback from the Swedish Research Council, but of course we will keep you updated as to the actual start of the study. And then I think my final slide. Yes, thank you. So I think the treatment of oligometastatic breast cancer is expected to offer cure to a select, or at least a specific group of patients. We have to select them carefully. No, we don't know for certain yet that it will be superior, but I think that we're going to do that, especially when we include all these patients of the same characteristics in our current clinical trials. I think one more button. Yes, very important is also, of course, that we use pre-specified modern imaging techniques. So I think that oligometastatic breast cancer will benefit from treatment. Thank you for your attention. Sorry about the technical difficulties. I hope it didn't divert the attention too much.
Thank you, Frederick. So we are on the time, but perhaps I just give Philippe the word to you. I know you've been answering by writing, but if you can just say about the questions on, can patients still be included in Aurora?
So the original goal of Aurora was 1,000 patients, and this was met. So recruitment stopped in February 2021, but Aurora is not finished as a program. So it will soon restart, but in specific breast cancer categories and in a smaller number of sites. But yes, Aurora will continue to recruit. Patients can integrate the program at the centers participating if the eligibility criteria are met. And there are working groups formed and are linked to Aurora that work on the data and the samples. And one specific working group is really focusing on de novo metastatic breast cancer, because we have samples there that were totally untreated. So a quite interesting subset of patients.
Thank you. We had also received a few questions before the webinar from some of you. For the sake of time, I am going just to give a brief answer to them. So there are questions about, can we ever make metastatic breast cancer curable, or at least a chronic disease, which currently it is not. And what we wanted with this webinar is to show you that, yes, that is our goal. And it's actually one of the goals of the ABC Global Charter is to improve the survival, perhaps in the different subtypes, with the new advances in treatment, with the early detection of metastases, we will be able to actually cure some patients. But I believe that our first goal will be to increase the survival to decades instead of just years, and therefore make it a chronic disease. So all these research projects, this is our goal, is to, at least for some patients, aim for the cure, and for the others to improve survival so much that they can live many, many years, some decades, with this disease. There was also a question about, do we know if the vaccine for COVID actually can lead to a recurrence of breast cancer? So as far as we know now, with the limited follow-up that we have, no. So what happens is that after the vaccine, some patients develop enlarged lymph nodes that look like a relapse, but then when you do the biopsy, you confirm that that is not an actual relapse. So it's very important to confirm after the vaccination that the enlarged lymph nodes, if they are related to the disease or related to the immune system response. And the last question was tackling a very delicate issue about childbearing, so pregnancy when you have metastatic disease. And this is, of course, something very difficult to tackle. During pregnancy, a lot of the treatments we use for metastatic disease are not possible to use. All the targeted agents, endocrine therapy and T-HER2 therapy, all these cannot be given during pregnancy. Some forms of chemotherapy can be given, but so the situation is so different from the different patients that you need to discuss with your own oncologist. But there has to be balance between stopping all treatment for the time of the pregnancy and delivery, and also considerations about your own prognosis. How long will you live to take care of the child? So this is a very difficult situation, but a situation we are starting to discuss, because some patients are living for more than 5 years. And so that's also a right of these patients to discuss this. So I think the technical difficulties made us lose a little bit of time, but I think I tried to address the most important questions you have sent, and also those that are in the chat. So I will finish by thanking all the speakers for having dedicated your time and being available here. Also to everyone who has attended. And also to the EORTC and BIG for their help in the organization. And let's keep talking about metastatic and advanced breast cancer, because that's the only way to overcome the stigma, and also to get more money for specific research. Thank you very much.